The reason I love home health is because I really believe in the spirit of what home health is, getting elderly people back up to their baseline ADL where they can just live their lives as best they can and avoid hospital trips as much as they can. I love that.
Hi, everyone. My name is Mariam Treystman from the Home Health Consultant, and today we have the pleasure of having Austin Degenhardt, Managing Partner of HHA Pros Consulting. Thank you so much for joining us. Can you tell us a little bit about yourself and your company?
Absolutely. Yeah. Well, thanks so much for having me on. HHA Pros was born out of my experience in home health. So I joined home health at a really turbulent time, August of 2020 in San Francisco. So you can imagine the normal marketing strategies were not working correctly at that time. And so, but my experience, I haven't been in healthcare forever. So when I came in, the team at the company that I was working at, HealthLink, they really wanted me to look at the sales and marketing approach from a fresh perspective. And so having not been in healthcare, I think it kind of helped me. But long story short, we built a new model, more focused there on kind of a traditional sales model, calling, setting an appointment, doing a presentation, which is an in-service, but doing a presentation and then asking for the business. And so it was a new experience for me because there weren't any contracts to sign or deals or opportunities. It was more this relationship kind of based thing, but we found a lot of success taking a more professional approach in that way. And so I spent 3 years. We opened up a new branch. We opened up a hospice branch. We doubled our census, and we found a lot of success. And the sales and marketing strategies that we implemented really went well. But what ended up really catching my attention and interest was as we were growing our referral base and we were seeing referral numbers from hospitals, SNFs, doctors all increase, our census wasn't growing at the same rate as our referrals. And we were hiring clinicians all the time. It wasn't that we didn't have availability. It was really that there was some gap there. And so I talked with the CEO and I really started digging into what that was because I had a hypothesis that there was something happening between referral to start of care that we were missing things along the way. And the company at that time was utilizing Kinzer as their EMR, but they were really tracking all of their referrals on a spreadsheet.
Like
on Google
everybody.
Sheets. Like everybody, exactly. And so I felt there would be some potential errors there and some things that get overlooked and a lack of data and visibility. And so I really started digging into that problem. And once I got my teeth into that, it was really tough to stop because the results that we started seeing, what we ended up doing is mapping that process, kind of each step, each stage that a referral goes through, who touches referrals, what's the communication channels. We really spent a lot of time mapping that process. And then along with the CEO, I led the project of building a system that would address that challenge. And so once we mapped the process, we estimated our conversion percentage from a referral that's placed with our agency. We estimated through the best way that we could calculate the data on the spreadsheets that we were at about 75% admission rate, which for me, it seems like that's about industry standard. And once we really mapped it all and we put a system in place that was tracking data accurately, it turns out it was 58%.
Wow.
For me, I have a diverse business background, technology, sales, different things like that. From a management and leadership perspective, to be 10 points, 15 percentage points off of what you think on a major key performance indicator was enlightening for me. It blew me away. And once we put the system in place, we ended up getting those numbers. Our first quarter was 58. The next quarter was 72, then 78. Now the agency operates in the mid 80s. And that's where I think really high performing agencies, that's kind of the really industry standard of real quality.
So it sounds like you put together a process that probably exists in other parts of business, but of course in healthcare it's kind of secondary to patient care and things like that. And so people just don't focus it on these kinds of elements as much.
That's exactly it. For me, what I was doing, it didn't seem like rocket science. It didn't seem like I had some unique insight to something. It was pretty obvious to me that this process should A, have a lot of attention on it because it's your primary revenue driver, referrals.
Right.
And that for me, with a sales and customer service background, every referral you get from the referral source to the actual patient themselves and their families, there's so many customer service elements along those lines that I felt that whole process should get a lot of attention. But like you said, in home health, there's so much attention on the clinical, which is where it really should be. That's the main thing we're doing is caring for patients. But I felt that similar amount of care dedicated to this process would yield results. And it really has. It really has.
That's fascinating. And of course, in home health, you have, like you said, marketing is very relationship based, just because, probably because it's an undifferentiated service. You can't really be that different from the next guy since it's so regulated and things like that. What did you find were some of like the top reasons for the drop off or of the referrals, let's say between referral and admission?
Yeah. So there's a couple things. In my system, I kind of stage it out. So a referral moves through more like a traditional sales pipeline, right? You have an opportunity, you've been prospecting, now they're qualified, now you're going to schedule a meeting. So I kind of took that framework and applied that to the referral to admission process, and we came up with stages. So, one of the first stages is just referred. And if you're in a busy territory with a lot of hospitals that are all on CarePort or ADA or any of the referral clearinghouses, that referral volume right there can be really high. In San Francisco, at a top agency that has the relationships, intake people might be processing hundreds of referrals a day.
Wow.
And it doesn't mean that they're going to be placed with them, but they just blast it out and say, hey, who can take this patient? So there's referred. Then there's the referrals that you accept, right? So there's a certain percentage drop off there. We out of territory, out of network with insurance, whatever that might be. So then you accept a certain amount of referrals. Then there's the referrals that are placed with you. So those are three already key metrics and differentiators that I feel are really important to understand what's going on in your on the sales and marketing engine of your business. But the place that really matters is the referrals that are placed with you. So, okay, that to me, the ball's now in our court. The referral's been placed with us. And from there, that's when the stages get really more specific. So two primary areas where referrals drop off. One was so simple, but it was when a referral needed DPCS approval. So the director of nursing or clinical manager, someone needs to review the case and to make sure that we can staff it. If it's a complex wound care or if it's Foley catheter, maybe we don't have the right nurse right now, but maybe tomorrow. It was those kind of decision points that I found referrals would drop off because anyone in home health knows the DON is the busiest person in the agency.
Yeah.
At least from my experience, hardest working, busiest people. So that was one area. Another one was the biggest one I found is a referral with incomplete information.
Oh, yeah.
Right? So it's missing H&P. It doesn't have a med list. The doctor didn't sign the form. Any of those kind of elements. When a referral comes in incomplete, this was less at the hospital level. Most hospitals send complete referrals in my experience, but when you're looking at the facts from a sniff or, from a doctor's office and It's just those referrals. What I found is when you needed to follow up to get information, who was doing it, right? So we had we relied heavily on intake to handle the whole intake process. And they would reach out to the marketer or the community liaison for help when they really needed it. Sometimes that help might be 2 days after we got the referral because the intake team was so busy. They called, left a voicemail. The doctor's office is busy. So now we're looking at 1 day, 2 days. A patient thinks they're getting home health. We don't have a complete referral. The doctor doesn't know what's happening yet. The marketer's just getting made aware. We're 2 days later. And that's where I found things really started to drop off, is things would literally get forgotten about because that referral from 2 days ago, that's a maybe without a complete referral. Now you have 100 new referrals that you're processing that day. And that's where some of the gaps really started to occur in the process, which is pretty early on in it.
I think what's unique in home health, and just probably other health, that's my experience, is in the home health industry, is in other business practices, there's a decision maker, there's a deal, and then it's done, and now you're just servicing the deal. But in home health, there's a lot of people who have to have input. Like, especially if you're getting the referral from a hospital, like you said, now we need to maybe find the doctor that's gonna be actually following it. Like you said, we need to check within the agency to see if we can staff it, if we have capacity in terms of the clinical care and not so many like kind of elements of it, that there are so many places a referral can just drop off if you're not careful about it.
Yeah. And especially when it's on a spreadsheet, it literally gets buried. It goes to the bottom. And, spreadsheet organization, the clinical people that I've worked with, they're so focused on clinical that some of the business fundamentals of how to organize a spreadsheet properly, most people didn't get that education. An intake person who's doing customer service and checking insurance and calling patients, they didn't take high-level Excel class in college, and they're not doing pivot tables, and, some here and there maybe, and then when you get to the nursing side, they're dealing with systems and software all the time, but it's EMR. It's not spreadsheets and data and metrics and all those kind of things as much. And so, yeah, literally things would get buried and we'd go through the intake sheet and, oh, what happened with this patient? And it's like, oh, we called, we left a voicemail, the doctor didn't get back to us. And we're like, that was 4 days ago.
Yeah. And there are time frames for these things. Like you don't just have some unlimited period of time to like get to the bottom of things. So, you have like the 48 hours to see the patient. And of course you can justify that with, various MD orders and things like that. But in the time it takes for you to get the act together, another agency can swoop in, or the patient can just straight up get hospitalized, or, whatever.
You hit it right on the head. In San Francisco, it's a super competitive market because San Francisco is 7 miles by 7 miles. And there are, I think, 9 hospitals in San Francisco alone. So the volume is crazy high. And we found all the time our nurse would go in for start of care, and there would literally be another nurse already there from another agency. And then you don't want to put the patient in that position of, hey, no, we're your agency of record. Talk to your case man. They just got discharged from the hospital or a sniff. They don't, is someone going to care for me? Just please,
No, they don't want to be in your drama.
Yeah. Yeah, we can't have, competitive home health drama stuff happening. They have plenty of trauma they've already been through. So, yeah, another agency could be there, or they would get rehospitalized. That happened more often than I would like to even really calculate because even from a doctor's office, those are usually, it's not an acute referral, but if someone needs med management and they're on a few new meds, that's the number one reason they rehospitalize.
Exactly.
So 2 days of taking meds the wrong way when a nurse hasn't come and set it up for you, now you're back in the hospital, totally avoidable.
Right. Agencies fighting over patients reminds me of that scene from Anchorman where like all the different like competing news stations are like meeting up to fight.
Oh my God, that would be that should be a meme. Only funny to home health, but exactly. Yeah. The different news times,
Yeah, yeah.
different channels. Yeah.
Well, I think, all of this background, and then you have to get the patient on board, and they're sometimes on board, sometimes not. And speed is really the name of the game in a lot of these instances. Like, because you might have home health or hospice coming from the hospital and also the doctor. Like, this is how you get those competing referrals, right? Like, where maybe the discharge planner works with this one agent, whatever, with this set of agencies, then the actual like PCP works with this set of agencies and so on. So you can actually have several home health agencies getting this referral, and whoever gets there first essentially is the winner. It's
Yeah. I always try to think about it from a patient perspective. Just the names of home health agencies can tend to be so similar.
yeah.
Everyone has a health component. I mean, not everyone, but Health Link, Health Flex, Health Now, home health expert, there's all those kind of things. And so from a patient perspective, it's like, okay, I have a nurse here. My doctor said to do this. My case manager said to do, why do I care, guys? Figure it out, please. I just want my care and to not have to think about it again.
They also don't always know that they're from different companies. Like, they just see some clinicians coming in and doing stuff, they're not
Yeah. Someone in Scrubs is here.
Yeah, yeah, exactly. Showing me how to do meds, and that's that.
Yeah.
So that's interesting. So you guys went through, you essentially audited the infamous spreadsheet that everybody has to track referrals. And I think what's interesting is the larger you would expect that the larger the agency grows, the more on top of it they would be. But because there's so much play, so many possibly like referrals, things coming and going, there's probably a little more like slop in the bigger agencies because things just get lost.
I think you're exactly right. And that's what we've found. It's actually been one of the challenges in my consulting, in my initial conversations with companies. If you are a single branch agency and you have a census of, let's say, 400, and you're doing $20 million a year, and you have a decent profitability rate, 15%, right? I mean, you don't have a problem,
Right.
right? Everyone's being paid, the ownership, leadership, everyone's in a good spot. You can be a 5-star agency and still have this problem that you just don't really know about. And that's the insidious part about it is, from a financial perspective, you're leaving money on the table. And of course, from a business side, that's never something you want to do.
It's like a cardinal sin of business.
Yeah, especially if it's not about hiring more people, right? It's just a workflow situation. So that's one. But the part to me that the reason I love home health is because I really believe in the spirit of what home health is, getting elderly people back up to their baseline ADL where they can just live their lives as best they can and avoid hospital trips as much as they can. I love that. But for me, if you are processing, 500 referrals a month and 2 patients get forgotten about and just never called because you have slop on the spreadsheet, they may get seen later. They may rehospitalize. It's not going to ding your agency because they were never your patient. So it's not going to hit your 2-day start of care rating. It's not going to affect you, but it affects the patient. And ultimately, long term, I believe it affects your relationship with whoever sent you that referral. So it affects your relationships with community partners. But the main thing is, if what we're doing in home health is taking care of patients, you can't forget about anyone.
Right.
If you don't have capacity, you refer them to someone else who does. You make sure they get the care in a timely fashion. That's what the whole CMS system is built on. And yeah, but I think you're right. The bigger it gets, actually, the more amplified. It's not the problem because on paper you don't have a problem, but it is. The problem becomes much larger. And once you have multiple branches, again, you'd think, well, oh, well, the larger agencies are going to have systems that all the information centrally located and all the data flows to one place where one team can see and analyze the issues. But ultimately, each branch is a community-based organization, even if they have leadership that goes, national. So, and if you're doing 20 million at one branch and 15 million at the other branch and the spreadsheet works, what's the real pull of the problem? You know, besides a lack of visibility, there's a lot of problems, but that is one of the insidious parts about it. It's not enough pain sometimes to take the time to solve it.
You actually touched on something very, very interesting and like really hit the nail on the head, which is you might not feel it in your company that, this one dropped off and that one dropped off, but it does ultimately hurt your reputation long term if you're kind of like forgetting about people. In that sense, the best case scenario is that there are multiple agencies fighting for this patient because someone just swoops in and takes care of it versus they fall in the cracks. I think that's at that point the best case scenario is that there is a competing agency.
Yeah. And, I really like that point because that's the other thing. I say that it doesn't affect you right now. You don't see it, but we all know home health. Home health is all about lagging indicators. Your 5-star patient score. You may not know it, but right now you're operating at 3 stars, but you have 5 stars. But once CMS processes all the data, in 3 months or 6 months, you're going to go down to 3. If you're not looking ahead and solving the problem, you're going to get dinged later. Your whole reputation is going to be affected by something that's happening now that the data doesn't show. And
I love what you're saying. This is from our end, especially, we have to work a lot with all of these reports that CMS lets out, but they are so far behind. Like even value-based purchasing just, it started a year ago, but there are a lot of agencies we work with. They don't have reports today. 1 year later, like after the start date, there's not a single report for them. And the reports that are coming out, they're from data in 2024. So you're like, I don't even know what to do with this information. Like, cool, 2 years ago, these were my numbers. And so on the one hand, it's good that CMS gives you all this information. But on the other hand, you end up like working off of information from, like 2 years ago. There's literally like new people born in the and made faster than we get data from Medicare about our information.
yeah, and you may have had a different clinical manager 2 years ago. Your primary nurses may be different by then. I mean, the competitive nature of home health and staffing, great companies do a good job of keeping their team, but keeping quality team in competitive markets is so hard. So the people who implemented some of the process may not even be there any longer from what you're looking at 2 years ago. So that was a part of the system that I implemented, and what I was trying to get across to leadership of the company was we need to track our own metrics that we believe are going to lead to the metrics that CMS calculates, right? And so the quicker your response time on all scripts or to a fax referral, the quicker you're going to get the information of, is this ours or is this theirs? The quicker that you get the information from a referral that is incomplete, the faster that feedback loop is going to be. The faster you move a referral from referral to SOC scheduled, the more likely you're going to be within the 2-day start of care timeline. And it all fed into trying to get at least to real time, ideally longer term getting to ahead, where you can start to forecast what's going to happen with all the data that affects how you're paid, affects, ADRs, audits, all the stuff you want to avoid like the plague. The further you can get ahead on tracking metrics that we believe are important that lead to these other lagging indicators, the better position you're going to be in to deal with all of the other things that home health is throwing at you all the time, which is nonstop.
All the time. And I think what's also interesting, this is you touched on it, and I just want to jump back to it. With these lagging indicators, like, you should be keeping your own data to know where it's going, because by the time you get this, it really is kind of worthless. But all of the surveying activities, like any time you interact with government for these purposes, there's a high emphasis on performance improvement, right, through co-op, things like that. They want you to use these standardized data sources that are like 15, not 15, but like 1 to 2 years old. So you're right, keeping your own data and having some kind of systems around that stuff is really important.
Yeah, I was just talking with an early stage client down in the middle of California, and he was on an EMR. I won't give too much data away, but he was on an EMR that I hadn't really heard of before. And he was early stage enough where he doesn't have a star rating yet. And so, but I asked him, what's your star rating? Where are you at? So I get a sense, because I really only like to work with clients that either have a good star rating or they know that they don't and they have a plan to fix it. Um, but I was asking him about his QAPI, and are you getting data on all of the CMS metrics like ability to bathe, mobility, ambulation, all those kind of, are you understanding what your numbers are so that are you going to be 5 stars, 4 stars, 3 stars? And his response was like, I don't think our EMR does that. So,
They don't
uh,
probably.
yeah, yeah. That to me would be a concern, because if you just started your agency and you're going to come out as a 2-star agency, there's not much sales and marketing can do to help you
Yeah,
if
right. You
you
got to get your fundamentals first as a healthcare company. Absolutely.
got to get that patient care down. And so much of that is charting. So many times agencies are providing quality care, but it's a charting issue. They're starting people off as too high on ambulation, and there's no room to improve for the physical therapist. But um, once you dial those things in, yeah, you gotta come with quality. I think that's going to be more and more critical. I think Medicare shows it every year that it's important.
Oh yeah, they keep increasing the reports that they're giving you, and like what you need to do with those reports, which is great. But agencies definitely need to have some kind of like mechanism for making their own data, keeping track of that. And can you let people know how they can get in touch with you if they're interested in your services?
Yes, LinkedIn is kind of the best place for me now. The company is HHA Pros, like Home Health Agency Pros. And so on LinkedIn, that's the best spot. I'm not really big on other social media platforms. And then Austin at hhapros.com. If you have any questions, concerns, thoughts, anything that, if you heard the podcast and wanted to talk more, learn more, or any of that kind of stuff, I'd welcome any kind of conversations like that.
Perfect. And we'll make sure that we link all your info so that people can easily get in touch with you. It's been a pleasure talking to you. And again, this is Austin Degenhardt from HHA Pros Consulting. And I'm Mariam Treystman from the Home Health Consultant. Thanks, guys.
Thanks so much, man.
Bye.